Hi, everybody. My name is Adam Pick, and I'd like to welcome you to the webinar titled Advances in Heart Valve Tissue Reconstruction. If I have yet to meet you, I'm the patient who started HeartValveSurgery.com nearly 18 years ago in 2006. The mission of our website is simple. We want to educate and empower patients just like you. This webinar, which has had over 600 registrations from patients in countries all over the world, was designed to support that mission. Now, throughout the webinar, you're going to be in what's known as listen-only mode, but I'd encourage you to submit your questions in the control panel on your screen, and I'll explain why as we look at the agenda for today. I'm going to go ahead and introduce the featured speakers. We're going to have a conversation about heart valve anatomy. We're then going to have a very deep discussion about heart valve tissue reconstruction. We're going to answer your questions, and then I'm going to ask you to complete a very quick 5-question survey at the end of the webinar. Now, when it comes to the featured speakers today, I am honored and I am humbled that they are taking time away from their very busy practices. Together, collectively, they, along with their teams, have performed not 1,000, not 2,000, but over 3,000 heart valve repair and replacement procedures. So who are they? Well, we're joined by Dr. Kristen Sell-Dottin, who is the Division Chair of Cardiovascular Surgery at Mayo Clinic, Arizona. Her clinical interests include minimally invasive cardiac surgery, transcatheter valve interventions, valvular heart disease, and high-risk cardiac surgery. Dr. Sell-Dottin, thanks so much for being with us today.
Thanks for having me.
Yeah, we are also joined by Dr. Shrestha, who is a professor of surgery, director of aortic surgery at Mayo Clinic, Minnesota. His clinical specialties include everything related to the aortic valve, aortic aneurysms and arch replacement. Specific to this conversation, aortic valve repair, reconstruction, and aortic valve replacement. Dr. Shrestha, thanks for being here.
Thank you very much for having me.
Yeah, so I could go on and on and on about all of the achievements and all the accolades of these two wonderful physicians. Instead, what I'd like to do is show you this. These are the faces, the smiling faces of patients from the HeartValveSurgery.com community who have gone to Mayo Clinic and had wonderful, successful outcomes. Whether it's Rosemary and Tom Rice, whether it is Scott Kinghorn, whether it's Herman Cantor, Wes Edens, and Gary Stanko. On behalf of all the patients at HeartValveSurgery.com, I'd like to welcome both Dr. Sell-Dottin and Dr. Shrestha. And to begin, we're going to turn it over to Dr. Sell-Dottin.
Thank you very much. So just to start, I wanted to put up a slide looking at our heart valve anatomy, right? So we're talking about heart valve repair primarily today. And there are left-sided heart valves in the main pumping chamber of the heart, which include the mitral and the aortic valve, which are in the sort of red portion of this diagram. The right-sided valves are in blue and are the tricuspid valve and pulmonic valve. So I'm going to focus largely on the tricuspid valve to start, which is, I would consider sort of the forgotten valve of the heart, as it is only recently becoming more studied and developed with treatment therapies. I will then briefly discuss the mitral valve. And as you heard in the introduction, Dr. Shrestha will then talk extensively about the aortic valve. So we're going to cover a lot of ground today. I'm going to try to keep this a fairly high-level conversation, and obviously we'll be excited to answer questions. Next slide, please. So first, tricuspid valve regurgitation, you're going to see that as TR throughout much of the rest of this talk, just to keep things simple. The tricuspid valve is a tri-leaflet or 3-leaflet valve. Okay, looking at the diagram on the left side, that's sort of looking sort of directly at the tricuspid valve. You can see there are 3 moving leaflets. And the most common type of tricuspid regurgitation is functional. So there are 2 main classes. Functional is the first and most common. This involves annular dilatation or stretching out of the actual annulus or where the valve is connected to the heart. Most of this happens along the inferior annulus. If you can see my mouse, the I here is for inferior or posterior leaflet of the valve, and this is where the majority of that annular dilation occurs. This can be caused by a number of things: heart rhythm issues, pulmonary hypertension, or even left-sided heart failure, either pump failure or valvular disease on the left side of the heart. And we'll circle back to these main topics as we go through a couple of cases here in a moment. The second main category of tricuspid regurgitation is primary TR. Now, this would include an actual mechanical issue with the heart valve leaflets and includes the list of things that you see here: rheumatic disease, tricuspid prolapse, ischemic TR, endocarditis, which is infection of the valve leaflets, and sometimes even trauma, which again, you'll see in our second case. Next slide, please. So tricuspid valve regurgitation. Why should we care? Well, it is actually fairly prevalent. There's at least moderate tricuspid regurgitation in approximately 4% of people over the age of 75. Okay, so moderate to severe tricuspid regurgitation results in higher mortality when we look at all patients who have elements of heart failure. And this is independent or separate from the LV ejection fraction or how well the heart pump is actually working. Okay, so this matters. Additionally, severe tricuspid regurgitation is associated with a mortality rate 2.5 times that of patients who do not have TR. Okay, so it's a big deal, but what do we do about it, right? So over 90% of these cases are functional tricuspid regurgitation, or that first category we talked about. And there are a number of symptoms that patients can develop: congestive heart failure, fatigue, peripheral edema or swelling, limited endurance, but also we can end up having both kidney and liver dysfunction related to this as well. Next slide. Case presentation. So our first patient today is going to be a 67-year-old man with severe mitral regurgitation. Okay, so left-sided heart failure, has a normal pump function with an EF of 60%, and has moderate to severe tricuspid regurgitation. Okay, his tricuspid annulus is dilated. 42 millimeters is bigger than it should be, but otherwise he has normal coronary arteries and is otherwise healthy. Next. So clearly this patient needs to have his mitral valve repaired, okay? And the question is, well, what do we do for the tricuspid valve at the same time? And so here is a diagram with a couple of options for different tricuspid valve repair techniques. The most common of them is what you will find in the top left, which is A, tricuspid ring annuloplasty. That white device that you see, it would be the annuloplasty ring, which gets implanted to help support the valve and also bring the valve back into a normal size. Okay, that is literally sewn in place and stays there to prevent the valve from stretching out again. Okay, the other examples you'll see are sort of iterations of a ring annuloplasty where we're also dealing with leaflet repair, or the sort of green straw looking structure is meant to be a pacemaker lead. And we sometimes will have to deal with those pacemaker leads and get them outside of sitting on top of the valve where it affects their function. Okay, additionally, the bottom 2 comments, the bicuspidization of the valve or a K-stitch is a different method of repair where we sew 2 of the leaflets together and make it functionally a 2-leaflet valve instead of 3, or a De Vega annuloplasty, which is effectively a ring annuloplasty. As you see in A, it's only suture material and no foreign body is put in. One final point about this, we call it a ring annuloplasty, but you may notice it's not a full ring. Okay, the reason for that is because the electrical system or conduction system of the heart sits in that area where we are not implanting the ring, because we do want to avoid damaging that and causing people to need a pacemaker if we can. Next slide. There are several surgical approaches that we can take. That's not going to be the main focus of what I'm talking about today, but know that on the left side, that would be the incisions for sort of a robotic approach. On picture right, you see a right anterior lateral thoracotomy, which is another minimally invasive approach. And down in the center of the screen, you'll see a median sternotomy. And so we can access the valve through all of these approaches. Next. Surgical outcomes. So severe tricuspid regurgitation, along with a number of these other factors, as you see listed, are associated with impaired survival. So for that reason, we address this problem when we find it. We know that there is less morbidity and mortality, or less complications, when we can repair the valve as compared to replace it, which is why that's our primary treatment. And tricuspid valve repair is the most common procedure done, and is typically done concomitantly or during some other cardiac surgery. Next slide. So case presentation 2, okay, we're going to pivot a little bit and talk about a slightly different setting of tricuspid valve disease. So 68-year-old man with a history of an orthotopic heart transplant many years ago. He has multiple other medical problems, okay? So he's obese, he has a kidney disease, as well as some lung disease. This gentleman has torrential tricuspid regurgitation from a flail segment. So in short, we do heart biopsies to monitor people after a heart transplant. And this patient, unfortunately, has one of the cords or attachments of his valve was injured during one of those biopsies. And so he now has primary tricuspid regurgitation related to that trauma. Over time, this has led to an extremely dilated right side of his heart, as well as an extremely dilated and big tricuspid valve. He does have significant dysfunction now of the right side of his heart related to this chronic valve problem. And interestingly, has a chronically occluded RCA, which is a right coronary artery related to transplant vasculopathy. And that will become important as we consider treatment options. Next slide. This is one still shot from this gentleman's echo. This right in the center of that screen is the tricuspid valve, and all of the sort of orange and yellow that you see heading up towards the top of the screen is the tricuspid regurgitation he has that should not be there. The other thing that you can't completely tell from this, but the right side of this gentleman's heart is extremely large, and in him, it's even larger than the left side of the heart. Next slide. So this gentleman needs a tricuspid valve replacement. There's not a good way to repair it at this stage. And our options include both a bioprosthetic or a tissue valve, or a mechanical valve prosthesis, okay? You see in the picture an example of a bioprosthesis being put in the tricuspid position. Thank you for the arrow. Risks of this surgery are numerous. This includes risk of failure of the right ventricle, a potential need for a permanent pacemaker, kidney failure, bleeding, death, stroke. When we look at isolated tricuspid valve surgery, right, where tricuspid valve regurgitation is the reason we are taking you to the operating room, we know that all comers, this is a high risk operation with a mortality risk of around 10%. Okay. And for some patients, that may be even higher depending on your other medical problems. Limited transcatheter options exist at this time. Next slide.
Dr. Sell-Dottin, real quick, a mortality risk of 10%. I'm sure a lot of eyebrows from our audience just went up. Is that part of a function of the fact that this has been the forgotten valve over the years and it's just being diagnosed at a later stage of the disease? Or is it just a much more complex procedure?
So the procedure itself is not necessarily more complex, but the sort of physiology that is associated with this is certainly more complex. And so often we're going to see, right-sided heart failure. We're going to see impacts on your liver function and your kidney function. And so in general, people who have isolated tricuspid valve disease are simply sicker patients than those undergoing, standard heart surgery. And I think for perspective, we would consider low risk cardiac surgery a mortality risk of about 1 to 3%. Intermediate risk would be about 4 to 8%. And anything above that is going to be considered high risk. Okay, just so that people have some idea, perspective of what we're talking about.
Great, thank you.
Next slide. So to touch briefly on transcatheter tricuspid valve replacement, there are multiple clinical trials underway. There are challenges associated with this. Okay, so these valves need to be quite big, and so the delivery system can be quite large. So 45 French is what that 45F means, is going to be something about as big around as my thumb. Okay, so that's a pretty big device to have go in through one of the blood vessels in your groin or your neck and safely deliver to the heart. Okay, we have challenges with anchoring these valves, or actually, getting them to stay in place, because we're not typically dealing with a lot of calcium or anything that will hold the valve where it needs to be. We worry about interaction with your conduction system, or possibly creating a need for a pacemaker, but also interaction with people who already have pacemaker leads across those valves. The recommendations are not standardized for use of blood thinners after this procedure. We don't know the long-term durability of this procedure, and there are similar risks to what we see with open heart surgery, minus the sort of, healing and the need to be on cardiopulmonary bypass. So it's a very exciting area that we'll talk a little bit more about, but there's still a lot of unknowns, hence the ongoing clinical trials. There are two main categories of these valves: orthotopic valves, which would be a tricuspid valve in the natural anatomical position, and heterotopic valves, which is where we actually place valves in your superior or inferior vena cava to sort of reapproximate a tricuspid valve, but we're sort of having to move it to a different place, presumably because we don't have a device big enough to deliver in the tricuspid valve itself. Next slide. This is a slide just showing you a picture of a bunch of the different options that we have for tricuspid valve therapies. You can see they come in a bunch of different shapes and sizes. They all anchor differently, and this is a part of where ongoing research and development is going. Okay, next slide. The TriClip trial or Triluminate trial, this is one of the earlier devices that we've used in trying to repair the tricuspid valve. This is actually using the MitraClip platform. So you see in that picture, the little white device that looks kind of like a clothespin gets pushed down below the valve leaflets and then actually grabs the leaflets on either side to pinch them together and try to prevent leakage through the center. And so it requires enough coaptation, or the valve leaflets, to be close enough that you can actually grab them with this clip, and that alone takes a lot of people out of consideration for it. But those who do qualify for it have had reasonable survival. So 93% survival and freedom from MAE, which is major adverse events, at 1 year, and a 40% reduction in hospitalization, as well as improved quality of life. So it's an option, but it's not something that's available for everybody. Next. The Evoke valve, I've chosen this as the one transcatheter TVR for us to discuss, as it's been one of the more commonly used ones, and we've had some really nice success in this trial. It would be part of the TRISCEND 2 clinical trial. We know that there are predictors for failure of tricuspid valve repair, which would include things that we've already alluded to, including torrential TR, so even more than severe is torrential, significant leaflet tethering, as well as a coaptation gap of greater than 7 millimeters, meaning those leaflets are just nowhere near touching each other. This device is delivered through a 28 French delivery system, which is probably about as big around as my index finger. So we're still talking a pretty big device. Next. This is a paper talking about the results of this trial. You see this is back in 2021, so there's certainly been more experience since then. This was based on only 25 patients and included the initial 2 sizes of this valve. They have since come out with a larger valve, which is now up to 54 millimeters. And so we're recognizing, I think, the need that exists within this space. They excluded patients who had severely dysfunctional RV or right ventricles, or who had significant pulmonary hypertension, because those are patients that are at increased risk of having a poor result. Okay, next. All of these patients were high surgical risk, right? So I think that's an important factor to know, is that this transcatheter therapy is not currently available to anybody. It's really designed and currently limited to people who are at high risk of surgery, because surgery is going to be the gold standard still at this point in time. You see these patients were older, they had significant heart failure, and it was predominantly functional tricuspid regurgitation, which again is the most common reason that we have TR. Next slide. The overall results were quite good. Technical success of over 90%. There was no interprocedural mortality, and people's heart failure symptoms did significantly improve. Okay, they had a couple of events that happened. Again, I'll remind you, this was 25 patients total. There were major bleeding episodes in 3, 2 new pacemakers in 2 patients, and 1 patient that required new dialysis. And so I think that just speaks to the risks that we're talking about because of how sick these particular patients are. Next slide. Back to case 2. So we have our 68-year-old man, right? History of heart transplant and his traumatic torrential tricuspid regurgitation. I know I've kind of muddied the water with us talking about the different options that we have, but what do you think? Should we proceed with redo cardiac surgery and a surgical tricuspid valve replacement? Or do we try to offer him a transcatheter tricuspid valve replacement? You know, he is a high-risk surgical candidate. He does not have any pacemaker leads in place, but as we kind of showed you in that picture, his heart is huge. His annulus measures 60 millimeters in one direction and 54 in the other. And I know I just showed you that the Evoque valve, the newest, biggest size is 54. Next slide. And this is just to bring us back to that echo picture again. Heart is enormous. And, you know, what is the best answer? I don't think that there is a black and white answer in this particular case. And that's part of why we have heart valve teams, which is pretty exciting. Next slide. Okay, this will be very brief. Case 3 is New Frontier. So 55-year-old man with end-stage liver disease and end-stage kidney disease on hemodialysis who also has severe tricuspid regurgitation. Okay, I think this is an interesting case because he can't be listed for transplant unless his tricuspid regurgitation is treated. But we can't treat his tricuspid regurgitation without a plan to treat his other organ failures. And he's got significant risk of worsening liver failure and bleeding with cardiac surgery. And so again, thinking back to the options we just talked about, do we think about a transcatheter procedure and then try to proceed with transplant? Or do we work with our abdominal transplant colleagues and work to do a concomitant or at the same time surgical tricuspid valve replacement and a liver and kidney transplant? And so again, I think we're starting to see exactly how sick these patients are, but it's certainly an exciting area. Next slide. So yeah, it's complex, treatment's often risky, but it's developing at a very rapid pace. Next slide. We're going to talk very briefly about mitral valve regurgitation because I know that's a hot topic for a lot of patients. This is very well published in terms of results and things like that. So we're going to try to fly through an example and talk about this from a high level. So revisiting our first case, right? Our patient who had severe mitral regurgitation and a flail P2 segment. Okay, next slide. So mitral regurgitation, valve on the left side of the heart as we started in the beginning, and mitral regurgitation leads to a lot of similar symptoms that you can have with other valvular disease. Next. Mitral valve anatomy. So here you see the mitral valve sitting in the center of the screen. It's sort of in the back of the heart near the spine. And when it is working properly, it kind of looks like a smiley face. Okay, but P2 is the segment labeled in that picture is the area that is most commonly affected when dealing with primary MR. Next slide. Okay, again, we have multiple surgical approaches, robotic, minimally invasive, sternotomy. The specifics of that will depend on the specifics of each case, but we have a lot more options than we did just a few years ago. Next slide. Valve repair. So this can involve a variety of things. Again, we can't exhaustively talk about this now because it's a whole day topic, but we can patch holes, we can reconnect the valve leaflets, we can remove extra tissue, we can repair the structure by actually creating new cords that support the valve, we can separate leaflets that are fused, and of course, we always have the other options of replacing the valve or mitral clip or other transcatheter therapies. Next slide. So this is a picture sort of showing us one of the more common procedures that we perform for mitral valve repair. So in this picture, you're going to see the top left, they are doing what we call a triangular resection. So the dotted lines is where that scissor is going to cut, that tissue is going to come out. Okay, and the reason that we call this a flail segment is all those little sort of finger looking things that are projecting, thank you for the arrow, are torn cords. Okay, and so those cords are torn and now that leaflet is not working properly. So we remove the damaged segment, we sew it back together, which you'll see in the bottom of that picture by the blue suture, and also to perform an annuloplasty. And so here again, you see that ring similar to what we had on the tricuspid valve, which is meant to reinforce the valve and provide support so it doesn't get stretched out again. Okay, next slide. Benefits of repair, it preserves all of the functional components of the subvalvular apparatus or the cords. Okay, this is associated with better long-term outcomes. In-hospital mortality, forgive this typo, is actually less than 1%, not greater than 1%, which is fantastic. And there is lower mortality and lower risk of pacemaker placement when we can repair the valve as opposed to replace the valve. Okay, additionally, we have more durable results, meaning that repair lasts longer than valve replacement. Next slide. So there are plenty of guidelines to help us in this area. Mitral valve repair is preferred for those who have chronic primary MR for the reasons we just said. And this should be performed at centers of excellence because it certainly can be a challenging procedure to perform. Early interventions should be considered for low risk patients. And the reason for that is our outcomes are really good and it potentially can last you the rest of your life. Next slide. Conclusion. So this gentleman, back to case 1 again, he underwent mitral valve repair. He actually had a P2 resection and an annuloplasty ring. We repaired his tricuspid valve and ligated his atrial appendage. He did great. He was discharged on post-op day 5 and continues to recover well. And I think that's the conclusion of my portion of this talk. Dr. Shrestha.
So good afternoon. I'm going to talk about aortic valve repair. Next slide, please. So way back, if you go 600 years ago, so Leonardo da Vinci, the great Italian artist, actually did a lot of anatomic dissections and also studied the aortic valve. So these are the drawings of Leonardo da Vinci, and he found out at that time, 600 years ago, how the aortic valve functions. Next slide, please. So again, like we heard previously, so the heart is just a pump, and we're talking about the valves. There are 4 valves in the heart. The only function is to make sure that the blood flows in one direction. So we are talking about the aortic valve now on the left side, and it is the valve between the left ventricle and the aorta. Next slide, please. So the aortic valve has usually 3 leaflets, and it lies between the left ventricle and the aorta, and the normal valve opening area is 2 to 3 centimeters. Having said that, 98% of the human population have 3 leaflets, whereas about 1 to 2% have only 2 leaflets. Next slide, please. So the diseases of the aortic valve can be stenosis, that means that is calcified, which comes usually with age, or some diseases like the rheumatic heart disease, or it can be regurgitation, which means a leaking valve, and the third one can be a combination of both. Next slide, please. So if you're now talking about aortic valve repair, it's usually for the regurgitation, because if the valve is calcified, of course, we can only replace them. So now when we talk about the regurgitation, it can be congenital. That means it can be someone who born, let's say with the connective tissue disorders, for example, Marfan syndrome. So what it happens is that because of the Marfan syndrome, the aorta starts to dilate and starts to pull on the valve so that there is a leakage in the center. It can be due to a bicuspid valve, where instead of 3 leaflets, there are only 2 leaflets. So people with this disorder usually start to have problems in the 3rd or the 4th decade of life. And of course, there can be an aortic dissection. If there's a dissection of the aorta, then it can also cause aortic valve regurgitation. And the other one possibility is if there's an infection of the leaflets, then of course the leaflets gets destroyed, and then one can have a regurgitation. Next slide, please. So when to operate? Now, of course, when symptomatic. So severe heart failure. But the problem is that with aortic valve regurgitation, these problems comes a little bit later. So the decreasing function of the left ventricle, there will be dilatation of the left ventricle, because with every heartbeat, when the valve's function was supposed to actually block the valve, the blood from going back to the heart, which can happen. So then the heart starts to dilate. And of course, in severe endocarditis, if there are any infections, there's a big thrombus of agitations, then of course one has to operate. Next slide, please. So now let's go into the causes of the aortic valve regurgitation, the leaking valve. So if the aortic root and the aorta is dilated, like in this picture, then of course the valve will be pulled outside, so from all the directions, so there'll be leakage. Next slide, please. So this is one of them, is the Marfan syndrome, where people with this syndrome, they are of course tall. There's connective tissue disorder, so that the aorta starts dilating. There can be another syndrome called the Ehlers-Danlos syndrome also. Next slide, please. In case of bicuspid aortic valve, instead of 3 leaflets, these people have only 2 leaflets, and there are different types, which was described by Professor Jeevers from Lübeck in Germany. So there are type 1, type 2. So these are the different types. Again, the next slide, please. So if you look at the how to diagnose, would be in old days, it used to be only conventional X-ray. On the left side, you can see the normal X-ray, now where there is no dilatation. On the right side, the ascending aorta is really big and dilated. So here in the right side of the X-ray, you can see another patient with a huge dilatation of the aorta. Next slide, please. But of course, now the standard is to do a CT scan. And even CT scans have also evolved. It was way back in 40 years ago that CT scans were first developed in Germany. And now you can see that in 2002, it was still black and white. But now with the new softwares, which is now a 3D, you can do a 3D reconstruction. So you can cut out all the tissues and look at the aorta. So the computer can do a lot of things nowadays. Next slide, please. And the other big advantage is that also, even if the patient is big, but the computer can reconstruct the whole thing, so you only see what you really want to see. So you can only see the bones, you can see the soft tissues, you can only see the aorta also. So next slide, please. So now what to do about it? Way back, that is almost in 1968, I think, in London, the first so-called the Bentel procedure was done, because it was first done by Dr. Bentel and Dr. De Bono. So nowadays, a lot of people know it as a Bentel procedure. What they did was they replaced the aortic valve as well as the ascending aorta in the same sitting. So in those days, they were replacing the valves if the valve was leaking and if the valve was calcified, along with if the aorta was dilated. Next slide, please. So the possibilities were either to do with a mechanical valve conduit, replacing the aorta with a mechanical valve. And the advantages are, of course, the mechanical valve. The durability is long, the gradients are low, it's easy to store, so you can just store it, and at the time of operation, you can just take it out from the shelf. And also the leaflets, when you are implanting, it can be turned. Religion-wise, it's neutral, because it's a mechanical valve. Every religious person, whatever religion they believe in, should not have a problem with that. It is cost effective, it's not very expensive, and there are no animal components. The disadvantage is that one has to take lifelong anticoagulation with warfarin. And some patients, not all, do complain that they can hear the valve and the noise. And the third one is that these mechanical valves they still leak a bit, so it will never be totally, competent. And of course, the other thing is that one has to be careful that these valves don't get infected, so that if one has such valves and needs to visit, let's say, a dentist or any invasive procedures, one has to take antibiotics beforehand. This is very important. The other thing, of course, is that if someone takes anticoagulation, then if there's always a bleeding risk. If one takes 2 months anticoagulation, they can bleed spontaneously also. And if one forgets or does not take anticoagulation for a long time, then the valve can thrombose. Even then, the small risk is also of embolization, small clots forming on the valves and embolizing. Next slide, please. So the second one is the tissue valve conduit. Either we used to make them ourselves, combining a tissue valve with the graft. But now, of course, one company has come up. I worked with this company for between 2007 and 17 to come up with this valve conduit. This is the only one now available in the US, prefabricated one. It makes our life easier. The advantage is that, of course, one has to take only short period of anticoagulation. I would say maybe 2 to 3 months at the most. There is no noise. The gradients are low, and it's also physiological. The disadvantage again is that I would say limited durability. The limited means that it could be 15 to 20 years, but again, it doesn't last forever. So if someone is, let's say, above 65 or 70 years of age, the chances are that if we implant this valve, they will not have to come back again, because one would, the valve would last longer. Of course, the endocarditis is still possible theoretically, and it is made from animals, so it has animal components. So if you are religious, especially if these two religions, if you are a Muslim, then of course, some people may have problems with a porcine valve. But again, the one below that comes now prefabricated is made from bovine pericardium. So unless, some strict Hindus may have problems with tissues from the cows, very, very rarely, because I have implanted a lot of these, and also in Hindus, they don't seem to have a problem there. Next slide, please.
Dr. Shrestha, I've got to ask the question. Here we're talking at HeartValveSurgery.com a lot about the lifetime management of valve disease. And I know you shared that this prefabricated biological valve conduit could potentially last the lifetime of that patient. But I'm sure patients are wondering, we're living longer lives. If by chance we do need to have another operation, is this something that perhaps a valve-in-valve therapy could address?
Yes. Thank you for asking me the question. Actually, when we designed this valve, the reason that it took 10 years, we started in 2007, I remember, and working together until 2017 was that we specifically made sure that this valve, if it should fail, let's say in 15 or 20 years, then we can do a valve in valve. So this conduit has markers to make it easy for the valve to be put in. And the second thing is that most of the patients with this disease have very large aorta. That means that we are usually putting large size valves, 27, 25, or 29, so that later on, then of course, a valve in valve is not only a possibility, it makes easier to put them in.
Well, congratulations to you
back.
and the team for getting us this far with this technology. It's fascinating.
Thank you. Yeah. Next slide, please. But again, if the valve itself, leaflets are normal, let's say, and only the aorta is diseased, then even in the late 70s and 80s, 40, 50 years ago, so surgeons started to do valve repair. So if only, let's say, there are different here diagrams showing that on the left side, if only the aorta was dilated, then of course you could replace the aorta with this tube graft and then have a competent valve, right? And then, but we also, because in your first slide that we were talking, people also started putting 3 stitches on the commissures to try to repair. That was in the 60s and 70s, but we learned that that does not work in long term. So that is no longer done. What we now do, that was called the crustalplasty. That was, I think, 50 years ago. I myself never did that because that was before my time. What one learned now is that one can then also replace the aorta with and also valve sparing. Next slide, please. So there are different techniques, especially 2 very renowned surgeons. One was the Yaqub. So Magdi used to work in, now he's retired. He used to work in London. He came up with so-called the remodeling technique where he replaced the aorta, but the root was still there. So he used to do that. The second one is Tyrone David, another professor from Toronto in Canada, and he came up with a replantation technique. With the reimplantation technique, the whole of the aorta is removed and the aortic root is reimplanted inside the graft. Because with the Yaqub technique, the root was not stabilized. So there came other techniques like with Lansack and Professor Schaefers from Germany, who then started putting ring outside. So next slide, please. So I'm talking more about the David procedure because I used to work in Germany in the biggest aortic center there in Hanover, and we had done the largest series in the world with more than 800 patients. But the technique was developed by Dr. Tyrone David from Toronto. What he did was that if the aorta was dilated, he used to take out all the dilated aorta and sew the valve, the whole aortic root inside this graft, so that there were 2 good things. One was that the disease aorta was taken out. The second is that because the graft was outside of the root, it prevented, even in Marfan patients, the root again dilating. He saw that in 92. He started that in 1992, and we could see that the results were good, so that the indications have been now expanded, not only for the Marfan patients now also, but also to bicuspid and even in acute dissections and younger and also older patients. Next slide, please.
Yeah, Dr. Shrestha, one other question for you. Obviously, you're doing everything you can along with your predecessors to save the natural aortic valve tissue. Can you explain, and we're actually getting some questions about this as we're having the webinar, can you explain the patient advantages for keeping your own tissue?
Yeah, I'm coming to that. So let's go to the next slide. Okay. So the biggest advantage, again, here, Dr. David showed that is after 20 years. He wrote this paper saying he had done 333 patients between 89 and 2012. And he had a follow-up of more than 10 years, right? So what he could show was that even after 20 years, the survival of the patients was on 72%. And freedom from reoperation at 20 years was 96%. That means that even after 20 years, almost 97% of the patients still had their own valve, which you can't say with if you replace it with a tissue valve. Then another advantage was that the freedom from thromboemboli was 92% at 20 years. So these people did not have to take any anticoagulation except aspirin, and there was no embolization, no thrombus. So that's a big advantage. No anticoagulation, and still you still have your own valve. The other thing was because the patients had their own valve, which is a living tissue, the infective endocarditis was very low. There was only one patient with infective endocarditis in 333 patients after 20 years. Right. Next slide, please. This
and just to slow down for the patients, because this is such an important point, is freedom from reoperation is fantastic. Survivability is great. And some folks, Dr. Shrestha, who may be newly diagnosed, they may not understand what thromboembolism is. That's you're talking about a clot or some form of potential risk for stroke. Yeah.
Because if you have a mechanical valve or even tissue valve, a small clot may form, because even a tissue valve is a dead tissue. It's not a living tissue, right? So the endocarditis risks are there. With this type of techniques, if you can repair the patient's own valve, because it's a living tissue, then the endocarditis risk is very, very low. Next slide, please. So in my own previous center, we had done about 800 cases. So we looked at our own data, but there are different techniques also with the Tyrone-Davis technique. So some people use a straight tube graft. I was doing most of them, but with a straight tube graft. But some of the patients, we have these Valsalva grafts also, special type of grafts. We took them away. I had done about 100 of these. But when we looked only at the original technique that Tyrone-Davis started in 1992, so between 1993 and 2019, we have done almost 700 patients, young patients, of course. And you can see that, because I saw also one of the questions whether you can do this type of procedure through a mini sternotomy, small holes. I did that also. I started that, I think, in 2008 in Germany, and done almost 100 patients with that also. And we also saw that with Marfan patients, more than 100 patients were had Marfan disease, bicuspid patients that were 71. So all sort of diseases. And we could show that even in expanded indications, the results were very good. So you can see here also, even after 20 years, the survival was 50% because we are expanding. In fact, the survival is not that great as with Tyrone-Davis, because my oldest patient was 84. So, so if you have an 84-year-old patient, obviously after 20 years, due to natural history, they would not survive. So we had a little bit less long-term survival because the patients were a lot older than from Tyrone-Davis technique series. And also the freedom from valve-related reoperation, even at 20 years, was 80%. This was because I was doing a lot of echo dissections and bicuspid patients also. So next slide, please. And now questions whether you can do that mini sternotomy. One of the things I was faced with was that you have these Marfan patients, they come at the age of 20, 25, maybe 30 years. And what I found with these 15-year-olds, 20-year-olds was that they come with, they know that we will do everything okay inside, but what they want is outside with a small incision and small hole. So I started doing that with a small mini sternotomy. But having said that, everything is done exactly like with a full sternotomy. We don't do any shortcuts. All principles of the aortic valve repair are meticulously followed, and no compromises are made. It's not about the incision, it's about the repair. But we do the same standard with a small incision. Next slide, please. So it's not enough just to say that it's possible. We've proven over the last 15 years, I think I must have published at least 15, 20 papers in international journals showing that, and we follow up every patient to show that this is possible. So this is just some of the publications. You can find that in the PubMed. The next slide, please. Again, another papers over last 30 years. We have published a lot of papers, over 20-year results now. Next slide, please. So, but the important thing is that if we want long-term good results, then on the left side are two bicuspid valve pictures from the two patients. On the left side, extreme left, you have a bicuspid valve. There's already some calcification. Even if you repair that valve is not going to last 30 years. Whereas on the middle picture of the bicuspid valve, that valve is going to last forever because the patient does not have any calcification. So what I'm trying to convince our cardiology colleagues is that please send the patients at an earlier stage before calcification starts. Because if the aorta is dilated, we know the patients are going to need a surgery sooner than later, right? So it's better to do them earlier. So with the right extreme right, it's a tricuspid aortic valve. Usually the tricuspid aortic valves are not calcified. So the results are better with tricuspid valve. But it's not because they are tricuspid, it's because the leaflets are in a better condition. So if you have a valve like in the middle, the bicuspid valve repair will be equally good to the tricuspid valve repair. The next slide, please. So again, this is a paper that Dr. Craig Miller wrote. So he is a retired professor of cardiac surgery, aortic surgeon in Stanford, one of the great big names in aortic surgery. And he said that, of course, now the decision the cardiologists face is that where to refer their young patients for that if they have this sort of disease. And what he says that, of course, these are difficult operations. So please come to centers where the centers do large number of these operations. The surgeon has to be very experienced, but the team has to be experienced also, the whole team. So please, he says that, it should be at the right patient, at the right center, done by the right surgeon. Next slide, please. So in conclusion, I would say that the David 1 procedure has excellent short and long-term results, very low rates of valve-related complications, bleeding, embolization, and even endocarditis because it is a living tissue. In patients with Marfan syndrome, careful selection is important. Do not come, one should not wait until it becomes so late that the leaflets are thinned out, so that you have to do it earlier. For morphologically intact valves, I think that repairs should be done. If a center cannot do repairs, especially in younger patients, please send them to centers where they do the repairs. And for elective patients, I think that's why they should be sent to such centers. And at least in selected patients, I would say that minimally invasive David procedures are comparable to full sternotomy. If the patients are really large, there are some chest deformities, it may be difficult. Otherwise, minimally invasive means that with a mini sternotomy is possible. And I'm going to show the last video of a patient that I did last year. And coming from Germany, because I moved only last year, I didn't have any knowledge of basketball, I have to say. Turned out he was a famous basketball player, and that's the first time I met a basketball player, actually. And let's hear his story.
Both visible and unseen. While about 1 in 5,000 people have the gene, which can be passed down to their children, many don't even know they carry it. And for some, it can be life-threatening.
Try to swing it more flat.
Harley Anderson remembers when she first noticed the early warning signs in her baby boy, Parker.
So he was about 6 months old. We woke up in the middle of the night one night and he was struggling to breathe and his chest was like super caved in. From there, I mean, it's been his whole life.
A years-long search for answers led doctors to test for Marfan syndrome, a disorder that affects connective tissue and can damage the skeleton, eyes, blood vessels, and heart. About 3 in 4 people with Marfan syndrome inherit it.
He's very special to me.
Many people with Marfan syndrome are tall and thin, with unusually long arms, legs, and fingers, like Parker's father, Evan.
Ready?
Yep. And while searching for answers about their son's condition, Parker's parents made a startling discovery. Despite living 30 years of his life with no noticeable symptoms of the disorder, both Parker and his father were positive for Marfan syndrome.
How do you explain the feeling of that light bulb moment?
Yeah, it's kind of surreal growing up. I was so healthy and then all of a sudden realized that, I have major issues.
Evan's long limbs were always an advantage on the basketball court, allowing him to play Division I college basketball at the University of Wisconsin. Now, he knew the dangerous condition impacting his son's body was also ravaging his, and his life was at risk. A CT scan showed that Marfan syndrome was weakening Evan's aorta, causing it to expand like a balloon. He needed surgery fast before a catastrophic outcome and possible death. Lucky for Evan, at the Rochester, Minnesota Mayo Clinic, just 2 hours from the family's home in rural Wisconsin, was Dr. Shrestha, one of only a handful of surgeons in the world with extensive experience in the aortic root repair he needed.
He was very lucky, I have to say, because a lot of these patients do not have any symptoms because the aorta starts getting bigger, but that doesn't cause any problems until it's burst. Then it's too late.
It wasn't until after the surgery that the Andersons understood how close they'd come to losing Evan.
He told us I probably had around 2 months left.
To be 2 months away from losing, my best friend. It's crazy.
An intervention that might never have happened if not for Parker.
Do you feel like your son saved your life?
He definitely did.
So again, this video was broadcasted, I think, last month, in August, I think, end of August in the NBC. So in this case also, like he said, he almost came at the last moment. The aorta was thinned out. That's why I said, that was really, really lucky that we could do him and we could repair his valve. So I'm sure that because the leaflets were still okay, so, he would have a long, the valve should last for a long time. So again, I'd like to request everyone, if the valve is still okay, especially younger patients, we should try to repair the valve. It is possible nowadays. We have 30-year results showing that it is possible. Of course, it's more difficult than valve replacement, but then for the patient, it's a big, big, big advantage because you live with your own valve, which is a living tissue. Thank you very much.
Yeah, great prepared remarks from both Dr. Sell-Dottin and Dr. Shrestha. And we're going to get to a very quick rapid fire. I know I can see Dr. Sell-Dottin, you're typing away and answering patient questions. We're going to answer some questions coming on the screen right now. Liza, I saw you're with us today. She asks, what is the latest advance for the treatment of mitral valve disease caused by rheumatic fever? Can it be repaired?
Good question. The short answer, and I typed some of this as well, the short answer would be sometimes. Heavy amounts of calcification certainly make it more challenging to repair a valve, and I worry some about the durability or how long that repair will last in the setting of significant calcium. And so this is something I would answer on a case-by-case basis, but primarily I think you're going to be talking about replacement in the majority of these cases.
Got it. Thank you. And moving over, I know, Dr. Shrestha, you talked about this. John asked, can a valve-sparing root replacement be done through a mini sternotomy? I saw we already talked about the approaches that you're using to get patients back to normal faster, but are there situations where you just can't do, I guess, a mini sternotomy and you have to do a full sternotomy?
Yeah, so again, I saw the video, which it can be done. I've done hundreds. The only thing is that only in the right patients, because if there's some chest deformities, then of course you can't do that. Otherwise, generally, yes.
Right. And Denise, this is a question she asks, my husband was recently excluded from the TRISCEND trial due to a large annulus. What other options does he have?
So I kind of alluded to this, I think, during one of our cases. We are, even within transcatheter therapies, we are starting to expand the number of people that we can treat as the devices are made for larger and larger annuluses. And so there are a number of different trials. So it could be a matter of looking at the variety of different trials available to find one suitable for the size of annulus that's present. Otherwise, the answer is going to be open heart surgery.
Great, thank you. And then this is a question just about the overall recovery. Valerie asks, are we comparing apples to apples for the recovery from a heart valve repair to a heart valve replacement?
I would say yes. I mean, the trauma is, opening the chest, and so that would be okay. I think the same thing, yeah. In the short run, at least, yeah.
Okay. And moving over to the question about bicuspid aortic valve repair, I know you touched on this, but James asks, I have a bicuspid aortic valve that is leaking during a repair. Do the surgeons make it a tricuspid valve? Do they do anything else to the valve to make it more durable or avoid a future aneurysm?
Yeah, so you saw in the video that we do not make it tricuspid. The bicuspid remains bicuspid. The problem with bicuspid is that these patients also have dilatation of the aorta, aneurysm. So that causes the leakage. So when we take out all of the aorta and put the whole aortic root inside this graft, so the graft prevents a future aneurysm. So that way it remains stable. But again, it's important in bicuspid valve, like the pictures I've showed, that you have to come early enough before the leaflet is already calcified.
Great, thank you. And this is a question from Stephen. I had this experience when I was a patient. He asks, I recently had aortic valve repair and aneurysm replacement. Why is my heart thumping so loud after surgery?
So is that immediately after surgery or after a long time? That's the question. And second question I have is that valve repair means, was the valve replaced with a mechanical valve? Because some of the patients do say that they can hear the valve.
Got it.
It's
And
the
I
nature of
I don't know the time horizon from Stephen, so but thank you for mentioning and referring to the mechanical valve as well. And let's move over to this question that comes up all about re-repairs. We've got a lot of patients, a big section of the HeartValveSurgery.com community that might be experiencing a repair failure. And Lori asked, I have a 38 millimeter annuloplasty ring that was placed in 2011 on my mitral valve. I was told I now have moderate regurgitation because the ring has shifted or was never placed correctly, and that a mitral clip could be used now for the leakage. Lori's also experienced AFib. She's had 4 ablations over the last 6 years, and she's still in a flutter. Dr. Sell-Dottin, I see you nodding your head. What are the considerations and procedures in a case like mine?
Yeah, I mean, this certainly can be a challenge. Re-repair is something that is sometimes doable. It really depends on the specifics of sort of where the leakage is coming from, and in large part how much tissue you have to work with. When we have valves that are heavily calcified and you don't have any extra tissue, it's much harder to sort of refashion the valve into something that works. The other thing here is I can't underscore the importance of, AFib and aflutter in this type of pathology. And so I think it needs to be sort of a comprehensive plan where you're really looking to address both the mitral valve disease and the atrial, tachyarrhythmia in order to get the best ultimate result. And so that could be a combined thing with surgery, or, a combined approach with potentially a mitral clip and an ablation. But again, unfortunately, I think it really depends on the specifics of the case, and this can absolutely be a challenge.
Great. Well, with that question answered, we're going to go ahead. Unfortunately, given the time, we're at 4 o'clock, but please don't end the webinar just yet. I want to take a real quick minute and thank all the members of the HeartValveSurgery.com for being on the line today, getting educated and getting empowered to take the best next steps for your own treatment in your life and the life of the family members and the people you love. I also want to take a second to say thank you so much to Dr. Sell-Dottin and Dr. Shrestha for your commitment to valvular therapy and other comorbid related cardiac conditions. We really appreciate you taking time away from your practice today and sharing all the wonderful things that you are doing there at the Mayo Clinic. Thanks so much. And what we're going to do now, in advance, I want to thank you for the survey that will be coming up on your screen in just a second here. And again, on behalf of everybody at HeartValveSurgery.com, thank you, Dr. Sell-Dottin and Dr. Shrestha.
Thank you very much. It's been a pleasure and an honor. Thank you.